Hi, I'm Krista Walters. This is Assessment 3, History Taking and Patient Assessment for Foundations of Paramedic Science. So the first thing when I'm walking into a room with a patient, I'm going to be looking for dangers. There's no immediate dangers in this particular room. The room and the patient are both easily accessible. From here I move on to response, and for response I'm using the AVPU scale. Hi, I'm Crystal from the Queensland Ambulance. Can you tell me your name, please?
Liam Baker.
Okay, so from his response I can tell that he was alert. His eyes were open when I walked in and he responded to me immediately. I can also tell that there's no blockage in his airway and there was no obvious strain in talking, so there was no effort with his talking. I can also see that his circulation is okay. He's not looking pale and there's no sweating. So from here I move into my history taking. So I understand you've called us here for some abdominal pain, Liam?
Yeah.
Can you show me where it is?
Standing here.
Okay. And what were you doing when it started?
Sleeping.
Okay. How long have you had the pain for?
It's only like been this bad just tonight, but for the last few days, 3 days maybe.
Okay. And what were you doing when it got really bad?
Woke me up, I was asleep.
Okay. So what have you been doing, what's been relieving the pain over the last 3 days?
I've just been taking some Panadol for it.
And did you take any Panadol since it woke you up?
Yeah.
And did it ease it at all?
No.
Okay. So on a scale of 1 to 10, 1 being no pain, 10 being worst imaginable pain, what would you rate it at now?
8.
Okay. And over the last 3 days, what would you rate it about?
It's just sort of gradually got worse and worse.
Okay. Okay. Do you have any allergies to anything at all?
No.
Okay. Are you on any medications?
No.
For anything?
Just the Panadol I've been taking.
Okay. When did you last have a meal?
Last night.
Okay. And did you have anything to drink with that?
Yeah, I had a glass of water.
Okay. When have you last been to the toilet?
Last night before bed.
Okay. And was there any pain with that?
No.
Anything abnormal about it?
No.
Any different colour?
No.
Different smells?
No.
Okay. Good. Have you had any injuries to that area recently?
No.
Okay. Is the pain anywhere else in your body?
No.
Okay. And does it hurt when you cough?
Yeah.
Okay. Can you tell me what it feels like?
It's just a real stabbing, sort of sharp pain.
Okay.
Just head down around here.
Okay. And is there any position in which you sit that you can get any kind of relief from it?
Sitting up.
Okay.
Sort of thing seems to help.
Okay, very good. So from here I'd move into taking some vital signs. I'd be taking a temperature. Some of the equipment I don't have with me, so I'd be looking at a low-grade temperature of about 37.5, a BSL of 6, which is within normal range, an SpO2 of 98%, again within normal range. I would take his respiratory rate. This is one of the things that I would try to do without the patient actually knowing that I'm taking it, as the respiratory rate is something that can be controlled to a certain level by the patient. So throughout my history taking, I was having a quick look at his breathing, and in this patient it's a rate of 22. The other thing I'd also be looking at is his pulse. So I'll take his pulse now. And slightly tachycardic at 110. The other thing that I'd also take would be his blood pressure. Now I'm going to take I'm going to take 2 readings. The first one is to get a systolic reading by palpation, and the second one will be a more accurate reading by auscultation that will give me both a systolic and a diastolic reading. Okay, Liam, so I'm just going to put this around your arm here.
Yep.
That's it. Okay, so I have my systolic reading. This time when I pump it up, I'll only go about 20 to 30 millimetres mercury over that reading. Okay, we're looking at 138 over 90. Okay, so with the baseline of vitals now worked out, I'd move on to focused assessments. Now the patient has been complaining of abdominal pain, so that is the first area that I'm going to start. I'd palpate the stomach, looking for any rigidity, any guarding, any rebound tenderness. Okay, so I'm just going to have a little feel of your stomach there.
Yeah,
Tell me if there's
sore.
any pain.
Just a little bit, not much. Yeah, down there.
Down there? Okay. The other thing I'd be looking at is I don't want to just assume that there isn't anything happening in the chest. So I'm going to listen to his chest just to make sure that there's nothing going on there. Okay, so I'm just going to listen to your chest, Liam.
Yep.
I need you to lean forward for me, and I'm just going to go under your shirt, okay?
Yep.
Okay, just take some nice deep breaths. Very good, okay. So his chest is, sounds clear, there's equal air entry on both sides. Okay, so from here on in we'd be looking at giving him some analgesic pain relief and transporting off to hospital. Unfortunately, a lot of the conditions within the abdomen show very similar symptoms. One of the things I would be able to rule out would be pancreatitis, as it would be tend to be in the upper left quadrant, whereas the pain we're looking at is predominantly in the lower right quadrant. So some of the things, the other common ones would be urinary tract infections and kidney stones. And we wouldn't really get a positive diagnosis of appendicitis until the patient was transported to hospital, where they'd follow up with urinary and blood analysis. ultrasound and CT. And if it came back with a positive diagnosis for appendicitis, he'd go into the operating theatre, have them removed. If it didn't come back with a positive diagnosis, be kept in overnight, monitored, make sure he didn't deteriorate any further, kept in with nil by mouth, and hopefully be improved, he'd be released. So thank you very much for your time.